All right, let's dive straight into this explainer. Today, we're taking a look at how medical professionals act as, well, basically elite detectives. Only they aren't looking for fingerprints or muddy footprints. Instead, they're reading diseases and trauma hidden deep inside the human body. By digging into radiographic pathology, we're going to see exactly how technologists and physicians capture and then decode these completely invisible clues. To solve these mysteries, we're following a pretty clear path today. First, the language of disease. Second, classifying culprits like cancer. Third, the art of X-rays. And finally, the visual evidence itself. Section 1, the language of disease. Understanding the basic terminology of pathology. Okay, so the crucial point here is understanding the difference between what a victim or, the patient feels and the hard, undeniable evidence a medical detective actually observes. A symptom is totally subjective. It's just the patient's perception of the disease, like a headache or feeling nauseous. Literally, only the patient can identify it. A sign, on the other hand, that's objective. It's a physical manifestation detected by the physician during an exam. Think of a fever, swelling, or a rash. And when you combine these signs and symptoms into a specific group that characterizes an abnormal disturbance, boom, you've got what we call a syndrome. We also have to be on the lookout for specific opportunistic villains. One term you're definitely going to hear in pathology is nosocomial. This strictly refers to a hospital-acquired disease. A classic example would be a staph infection that a patient just happens to pick up while they're being treated for something else entirely. These opportunistic pathogens are exactly why rigorous infection control practices in healthcare environments are so absolutely critical. I mean, you really don't want your sanctuary of healing to turn into the scene of a new crime, right? Section 2, classifying the culprit, cancer. How oncologists stage and grade malignant neoplasms. Now, it's really important to remember that cancer is really just an umbrella term we use to denote various types of malignant neoplasms. We actually classify them based on their biological origin. So, for instance, a carcinoma is a type of cancer derived specifically from epithelial tissue, like an adenocarcinoma of the colon. On the flip side, sarcomas are cancers that arise from connective tissue, like a fibrosarcoma. Knowing this origin tells the oncologist so much about how the culprit is going to behave and spread. And this classification builds right into the TNM staging system, which is this globally used step-by-step method to evaluate the disease's severity and spread. Endorsed by the American Joint Committee on Cancer, this is basically the ultimate profiling tool. T refers to the size of the untreated primary tumor. As it grows, we look at N, which indicates regional lymph node involvement. And finally, M stands for distant metastases, meaning the cancer has actually seated itself in distant organs. This shorthand notation is absolutely essential because it facilitates treatment planning and gives a very clear indication of prognosis. All right, let's make sure we're fully ready for our third session here. Section 3, the art of X-rays, the physics of capturing the perfect clue. To actually capture these clues, technologists literally have to adjust their equipment on the fly based on the suspected disease. Think of it kind of like shining a flashlight through a really dense forest. Additive conditions actually add fluid or tissue, which makes the chest denser. So the technologist has to increase the radiation just to push through it. Subtractive conditions do the exact opposite. They add extra air, which means you have to turn that flashlight down to avoid completely overexposing the image. To put this into perspective, seeing these physics in action reveals why technique is just so vital. If a patient has pneumonia, or say cystic fibrosis, that extra fluid or tissue in their lungs is additive. You absolutely need higher energy to penetrate it. Conversely, a condition like emphysema actually traps extra air, which creates a subtractive environment. If the exposure isn't actively reduced in that case, the resulting image is just going to be a total blackout, completely wiping out the delicate visual clues the radiologist desperately needs to see. And, the physical setup matters immensely too. You've probably had a chest x-ray at some point and wondered why they position you the way they do. Well, the standard projections are erect posterior-anterior, meaning the beam enters your back and exits your front, and a left lateral. Because the heart lies in the anterior part of the chest and mostly to the left side, this very specific positioning places the heart as close to the image receptor as possible. It's exactly like making shadow puppets on a wall. The closer your hand is to the wall, the sharper and more true to size the shadow is going to be. By placing the anteriorly located heart right up against the receptor and stepping the X-ray tube back to exactly 72 inches, technologists minimize magnification. That gives our detective a true-to-size representation of the chest cavity. Section 4. Bones, Bugs, and Breaks.
examining the visual evidence of trauma and disease.
It is both terrifying and honestly pretty fascinating to see the visual evidence of how cancer spreads. When a primary tumor metastasizes to the lungs, which usually happens by traveling through the bloodstream or lymphatic system, it leaves behind these multiple rounded opacities all throughout the lung fields. Radiologists refer to this characteristic presentation as a cotton ball appearance. It is a stark, undeniable visual confirmation of advanced neoplastic disease, captured perfectly on film. Now, in stark contrast to the lungs, let's consider what happens when a bug attacks the skeletal system. Because tuberculosis isn't just a lung disease, folks. When the Mycobacterium tuberculosis infects the bone, which is often the hip, knee, or spine, where it's known as Pott's disease, it acts as a chronic inflammatory agent. The radiograph reveals this highly destructive, literally worm-eaten appearance at the ends of the long bones, where it slowly destroys the epiphyses and spreads right into the articular cartilage. When they are looking for traumatic breaks, detectives are searching for very specific, often incredibly subtle clues. You see, a fracture isn't always some glaringly obvious shattered bone sticking out of the skin. Sometimes it's just a tiny, tiny radio-opaque line where fragments overlap. Radiologists are looking for a break in the normal bone contour, maybe a slight interruption in the spongy trabecular pattern, or even just a slight bulging or buckling of the outer cortex. Sometimes the bone itself actually looks fine, but soft tissue swelling or fluid in the joint and effusion just screams that a fracture is hiding somewhere nearby. And this is exactly why taking two images at 90-degree angles is a non-negotiable rule in trauma cases. A skeletal injury might look pretty well aligned from the front in the AP projection, but then when you consider the lateral projection, the side view, you realize the bone fragments are completely displaced and just devastatingly out of alignment. You can literally never understand a three-dimensional mystery without looking at it from at least two different perspectives. So I'm going to leave you with this final thought today. The human body is essentially a canvas of clues, just waiting for the right detective to uncover its secrets. From the precise physics of adjusting exposure for an additive pathology to recognizing the subtle buckling of a cortex in a hidden fracture, medical imaging is this incredible intersection of technology and biology. Next time you look at an X-ray, will you just see bones and shadows? Or will you see the invisible clues of the ultimate medical mystery? Keep learning, stay curious, and we'll catch you in the next explainer.